Thank you very much. Welcome, ladies and gentlemen, to our latest panel here at Conhome, which is a vision for health, delivering for people with long-term conditions, which I'm very pleased to say we're doing in conjunction with the British Heart Foundation, the Stroke Association, and Asthma and Lung UK. My name is William Atkinson. I'm the assistant editor at Conservative Home, and I'm very pleased today to be joined by Lord Bethell, the former health minister, and a member of the All-Party Parliamentary Health Group, who also wrote a very good article for us a couple of weeks ago, which I edited, so I urge you to all, it needed very light editing, I'd like to point out.
It ended up very good.
Yes. So I could all urge you to go and read that. Juliet Bouverie, OBE, I should say, who is the Chief Executive of the Stroke Association, Paul Ristay, the MP for Peterborough and a member of the Health and Social Care Committee, and Kathleen Fallon, who is a patient and public voice campaigner for aortic dissection. Is that the right word? There we go, dissection, yes. Yes, so a very varied and very interesting panel today. But what we're addressing in terms of long-term health conditions, I've got a couple of stats here. 9.1 million people in England are projected to be living with a major illness by 2040, and that's 2.5 million more than in 2019. I think we're actually seeing a trend towards perhaps potentially 1 in 5 people living with a long-term health condition. Now, we all want to be living longer, but that puts obvious stresses on the NHS and other aspects of the state. So I think our discussion today will be seeing how governments and other aspects, charities, voluntary groups, etc., can deal with these particular issues, and what other choices that individuals need to be making to both cope with and indeed try to avoid long-term health conditions. And the format of today we'll aim for a 3 minutes or so opening speech from our various panellists on this theme. Then I will probably ask a couple of questions, then I'll aim to turn it open to you in the audience. I know we've got quite a lot in here today, so I'll try and make sure you get as much an opportunity as possible to ask questions. I would like to say, classic thing, when I ask for a question, I would very much like a question rather than a monologue. I'm sure there will be an opportunity to discuss various issues with our panellists afterwards if you so wish to. But without further ado, can I ask Lord Beth to kick us off?
Thank you very much, and thank you very much for hosting this event, a really big priority subject. Juliet and I were just talking about the legacy of the pandemic, and there were some horrible legacies, but one of the good ones was there did seem to be a little bit of a consensus around the future of health. And one of the things we were looking for was the prevention white paper and the disparities white paper, two massively important issues where there seemed to be real momentum for trying to address some of the issues and bringing policy together. I'm afraid to say that momentum has not been sustained. In fact, I would say it's gone into reverse, if anything else. And the major conditions white strategy paper, for me, was a sad moment because it meant that the preventions white paper and the disparities white paper got sunk, really, and instead we coalesced around something that didn't really have very clear teeth. We saw the establishment of OHID, which should have been a high point in trying to address upstream issues. But in fact, that has been defunded. It hasn't had the cross-governmental impact that was expected of it when it was first founded. And I'm afraid its impact hasn't been where any of us would have liked it to have been. Instead, we've seen announcements on leaflets in cigarette packets, and we've seen a little bit of speculation that there might be a New Zealand-style grandfathering arrangement around cigarettes. But other than that, there has been very, very little to address either disparities or prevention. And I find it really difficult to think of anything that has made a big impression from the major conditions strategy. Now, it did address some of the big issues, which is good. Workforce shortages, fragmented care, digital infrastructure, and I think Paul's going to say something about that, new treatments. My goodness, all of those are silos that need to be addressed. They need budgets and they need action. But it didn't address early detection, lifestyle interventions, and public engagement. the kind of upstream interventions that are going to be needed in order to keep people out of hospital, to reduce the amount of disease in the country, and to, frankly, maintain the sustainability of the NHS. Now, the result of that is that we are seeing the poor health of the country hit the economy really hard. The OBR estimate that next year workforce absence alone will cost £20 billion. £20 billion is a massive amount of money. Anything over £3 billion is quite a lot. £20 billion is a colossal amount. And politically, for the Conservative Party, this is going to hit us hard in the polls. Richard Sloggett wrote a punchy piece that some of you will have seen this morning, and I concur with his analysis. If we cannot come good on the 2019 commitments that were made in the general election by Prime Minister Boris Johnson, then the electorate will judge us really hard. So I would like to spell out a message that is that we need to turn around. We need a U-turn in this area, away from a faux focus on operational optimization and towards a much more heavy commitment to preventing to disease, pre-treatment, early diagnosis, and trying to reduce the burden of disease on patients, on the taxpayer, and on the NHS. Thank you very much.
Thank you. Juliet?
Great. Good morning, everybody. Nice to see you all. I'm Juliet Bouverie. I'm Chief Executive of the Stroke Association. Really delighted Conservative Home are hosting this reception. And I just wanted to acknowledge the really great collaboration that the Stroke Association has with British Heart Foundation and Asthma and Lung UK. We work together on the CVDR programme with NHS England, and it's a really strong collaboration. So it's nice to be here. So I'm going to say a few words about stroke, and then I'm going to broaden out into some wider messages for the health and care system. So stroke is horribly prevalent. Stroke strikes every 5 minutes. People go from living a normal, independent life to suddenly, within hours, often becoming very disabled. It's a really tough condition to live with. Most people associate stroke with the sort of physical kind of mobility and balance problems that stroke produces, but it results in huge kind of mental health problems. 40% of stroke survivors have something called aphasia, which means they really struggle with their speech and communication, an awful lot of cognitive impairment. I could go on. It's a really tough condition to live with. And it's a condition that currently costs the UK economy a lot of money because of the extent of disability that stroke causes. Stroke currently costs the UK £26 billion a year, and that's actually going to grow to about 75 billion by 2035. So it's a really costly condition, and it's costly to individuals and families too, because a lot of stroke survivors and their carers are basically housebound, struggling at home with kind of everyday living because of the extent of the disability. But there is good news. I mean, a lot of people think stroke's just a condition of older people. There's a sort of fatalism around it in political and public terms. But actually, stroke is both preventable, treatable, and recoverable. We know that 80% of strokes could be prevented due to modifiable risk factors, the most notable being hypertension. Stroke is eminently treatable. If people get to hospital quickly, they can get access to thrombolysis and thrombectomy, which can significantly reduce the disability associated with stroke and therefore the cost to individuals and the state. But unlike most neurological conditions, it's also recoverable. The brain can retrain itself, and so stroke survivors can make this absolutely remarkable recovery. And I've got to say, we're feeling pretty optimistic in some ways in stroke services at the moment, because there's some fantastic innovations in stroke treatment and care. I was just saying to Lord Bethel, that we've now got nearly 90% of hospitals in England that are implementing artificial intelligence to augment stroke consultant-led brain images. We've got video triaging, where paramedics are talking to stroke specialists as they're conveying a patient to hospital, so that everything is lined up when they arrive. We've got fantastic innovations, not just in stroke, but in cardiac and asthma, in rehabilitation. You know, pulmonary rehabilitation makes a massive difference, stroke rehabilitation and cardiac rehabilitation. So we've got a lot of evidence of what works, but it is frustrating. The system is just not geared up at the moment to implement what works. And we see shocking inequalities. I mean, it really depends on where you live as to whether you're getting access to these evidence-based interventions. And for some of them, like thrombectomy, which is a specialist procedure where the clot can be physically sucked out of the brain, not only are there massive inequalities across England and the UK, but we are lagging way behind our global partners. It's embarrassing. We're way behind Germany, Portugal, the US, Australia. I mean, I could give you the stats, but it's really quite, we should be ashamed, actually. And so I think we need a lot more political leadership for stroke, cardiac and respiratory conditions. That political leadership will in turn influence the ICSs to be prioritising our conditions, which they're really not doing at the moment. And yet for each of our conditions, they're such investable propositions because you put money in and guess what? You're reducing disability and long-term costs to the system. And we also really need to respond to what patients say. We've just completed the first ever stroke PREMS, patient-reported experience measures for stroke. And once again, it tells us what patients need and want, what good experience feels like for them. They want to be more involved in decisions. They want support with their emotional and psychological support needs. I mean, you go from being able-bodied to disabled overnight. No wonder you're a bit traumatized. Yeah. You need psychological support to readjust. People want support with returning to work. They want vocational rehabilitation. People want access to life after stroke services because they want to get on with their lives. So we really must respond to what patients say they need and want. So I would call on the government to invest in CVDR conditions. You can save brains, save money, change lives, and this is a huge population. Was it 9.1 million by 2040? Yeah. These conditions can be exemplars for how to treat everybody basically with major conditions across the UK.
Thank you very much, Julia. So I think my late grandfather had a stroke, and I'm sure there are many people in the audience with similar experiences. So thank you for speaking on it both so passionately and sort of bringing us up on where we are in the current state of it. But talking of the need for political leadership, Paul, can you can you give us your thoughts?
Well, thank you very much indeed. So I want to open up by just talking about 4 people in my constituency, 4 typical people. The first is, a person in their 60s, got cardiovascular disease, probably got diabetes too. They may have arthritis or musculoskeletal disease as well. And as they get older, they will probably develop dementia. So several things are happening to this patient. It's your heart, it's your body, it's your mind. Okay, and these are long-term conditions that we have to address. Second is someone that's a surgery called Thisomore surgery, which is in the centre of my constituency. Inevitably, they're Eastern European. English is second language. They've got a very physical job, and they smoke and they drink. And these persons are going to present, much earlier in their lives than they would. And prevention is the sort of key, to this person's condition. Also, a child who perhaps has got a asthma or another type of lung condition, perhaps living in a home which is not adequate, with damp or with mould. They may have a neurodiverse condition at the same time, and maybe have parents on low incomes. And again, early intervention into this young person's life will make a huge difference to their chances moving forward. And finally, I'm talking about a man or a woman, perhaps with COPD, and of working age, but perhaps not worked since COVID and are on working age benefits. Again, will this person perhaps in their 50s ever work again? So these are all sorts of people that in my constituency of Peterborough, people I meet all the time actually. These are real people that I meet. And each of these times, early intervention and prevention and pre-treatment, some of the things that Lord Bethel was saying, I think would make an enormous impact on these individuals' lives. And I'd just like to suggest some other ways where I think we can improve outcomes for these individuals with long-term conditions. Yes, there's prevention and pre-treatment, we heard that. I think that's absolutely right. What does that look like? I mean, we can talk about it a little bit in Q&A, but it's talking about the intervention at statins at 40 and things like this, where perhaps not presenting with a condition yet, but they ultimately will be able to improve their outcomes later on. But then 2 other things as well. The first is data and transparency, because we only improve by having data and transparency. We used to have political leadership in our NHS, believe it or not, but then it became a good idea that we let the NHS become independent from sort of political evaluation and control. I'm not sure that's worked in a controversial way, because if I want to turn around and challenge a service specification or a commissioning policy locally, you can't find it, but maybe it's page 267 of a commissioning document on a website somewhere that says that hip and knee operations, if you like, are only given to people with BMIs below 30 or below 25 in some ways. Well, that would be me out. So there are lots of kind of situations here where we don't have that scrutiny, that transparency to try and improve outcomes for patients. And I think that's key. And the last thing I'll talk about is technology. Because I think during COVID, we did see actually a lot of innovation in technology and a way we're changing things. But are we seeing those things now? And I think ultimately the NHS is pretty bad, if I'm honest, about learning from itself. It'll do something wonderful over here, where we are improving outcomes for people with long-term conditions, but someone may turn around and say, actually, it doesn't work over here. Well, hang on a second. What's good in perhaps Runcorn or in Doncaster will be also good in places like Peterborough. And so we need to get a lot better at that. I also, by the way, completely agree with what you said about mechanical thrombectomy. I think we need to pick winners, and we need quite often that political leadership to do that, because who remembers what we did with the cardiovascular strategy many, many years ago, where primary PCI was at pace and scale rolled across the country, and that saved countless lives. Mechanical thrombectomy can do the same, and it does sometimes require a bit of a Gordon Brown clunking fist, if I'm being honest, to actually try and get these innovations. And it's difficult for me to say that as a Conservative, but sometimes to get these innovations, across the NHS. Mechanical thrombectomy is a no-brainer. Of course we should be doing this. Of course we should, and we should also prevent sometimes, if I want to go into the detail of it, the professional guarding of these procedures as well. We've got lots of interventional cardiologists who can do these procedures, and we can roll them out at pace and scale. And why this is not happening mystifies me, and it's costing patient outcomes. I wasn't going to go too specific on conditions, but as you mentioned, mechanical thrombectomy, I'm 1,000% behind you.
Very good. You heard it here first, ladies and gentlemen. Conservative MP says we need to be a bit more Gordon Brown when it comes to...
I didn't quite say that.
Yes. If anybody from Guido Fawkes is in the audience. Anyway, and finally, last but very much not least, Catherine.
Thanks, William. So thanks so much for the opportunity to join this panel this afternoon. It's certainly a topic that's really, really close to my heart. I'm Catherine Fowler. I'm a mother of 2 beautiful children. I actually work full-time in the energy industry. And last summer, I was awarded a British Citizens Award for my contribution to healthcare. I suppose my interest and my journey started 8 years ago when I lost my father to a misdiagnosed aortic dissection. Dad's sudden death had a really catastrophic impact on our family. Clearly, we were all in serious shock, and my mother suffered post-traumatic stress, followed by an accelerated onset of Alzheimer's. So my sister's brothers and I, we became carers for our mum overnight, and really just struggled with the day-to-day of managing care for mum, working full-time and managing family life as well. But I suppose from the outset, really, I was really driven to turn my pain and my upset into what happened into a passion. And for the last 5 years, I've been volunteering for NHS England as a public patient voice for the Clinical Cardiac Reference Group and also for the Clinical Policy Unit. But I'm not here today in that capacity. In the weeks following my father's death, my sister and I created an online petition. One of those lovely change.org petitions. And we thought it would go viral, but it didn't. But it was, I suppose, a really way to kind of harness and amplify the voice of others calling for change for our Secretary of State and the Secretary of Health and Social Care. And we were asking for change in process, education, policy change, and improved diagnosis, which I think are probably all of the key themes we've touched upon. So although it's one of the smaller conditions, I think the key themes are absolutely the same, and I'm sure a red thread that will run through our discussion in the next hour. In 2021, I co-founded the Aortic Dissection Charitable Trust, along with Pauline Latham and Mr. Graham Cooper. It was the first charity for aortic dissection in the UK, and we're delighted to be working with NHS England and the Department of Health on policy change across the patient pathway. There's definitely some great examples that we might get the chance to talk to around the power of patient voice, public involvement and charity involvement too. We've been really busy in creating resources for patients to really help them better manage their lifestyle living with this long-term health condition. We provide online resources for medical professionals, and those have reached over 200,000 medical professionals to date. And we were delighted to be in a position to also start awarding research grants for such a young charity and only 2 years in. I think that the whole community and everyone who's been involved, we've got a lot to be proud of. I'm really aware that aortic dissection, I think William, how do we pronounce it? There's so many people have not heard of this condition, but it kills more people than road traffic accidents in this country. And although it presents very, very acutely, half of the people die in that acute phase. Those that do survive have a long-term health condition, and they require secondary prevention measures, long-term surveillance, and 30% of these patients will also require further surgical interventions on their aorta. So, yeah, I'm really delighted to be part of this conversation this afternoon, and I think there's some really interesting themes that have been raised already around the importance of leadership. I think there's certainly an important role for how patients and community can become more involved and follow the signposts to be more proactive about their own care when they know how and the education is there. And clearly early diagnosis is a really, really important issue for this condition and so many other conditions, as well as prevention. And I think there's certainly a role for how we can get on the front foot for inherited cardiac conditions as well. And the role, I suppose, for follow-up. So people who are living with these conditions, how do we support them? How do we support them to have a full life, to get back to work? We talk about it from an economic position, but Paul, you're referring to, these are real people. People
Absolutely.
want to live full lives, and that does include, working and contributing to. Over 50% of people who are impacted by this condition are under the age of 60, and it's very, very challenging for those individuals to access support for follow-up, for both their physical health in rehabilitation and also their mental health too. In fact, I've just come from Derby this morning, where we've been working with a clinical psychologist and a group of patients to create resources on how we can help patients with this disease live a better life and to normalise some of the feelings that they're having when suddenly, very much like stroke, their lives are turned upside down and living with disabilities and challenges that they will not have experienced before. But the outcomes for this condition are also very good when it's diagnosed and treated on time. It has an 80% survival rate, and people can do very, very well. I think innovation and technology is also an interesting topic, which I'm sure we'll cover today. And often I think just the word innovation drives us to a place of future gazing. And for me, I think in some of the work that I've done with NHS England and a lot of the regional cardiac groups in the design and implementation of the acute aortic dissection toolkit, there were some really, for me, quite surprising challenges and barriers to that implementation, processes that I would have thought as a layperson should be super simple, like transferring a CT scan from an emergency department into a specialist centre. That is something that the majority of the regions have not been able to resolve. So I think when we talk about innovation, I think we need to make sure that we're focusing on some of the systematic problems in the here and now and really do the basics brilliantly so that we can then, gaze into I hope what will be a brighter future. And I loved your tweet this morning about we are not short of opportunities with this challenge. It's all about action. That's something that I'm really, really passionate about. What can we do? I think that there are, a huge amount of challenge within the NHS, but there is a huge community of advocates out there who are waiting to be harnessed, I suppose, in supporting the cause. So thanks so much for being able to be part of this contribution today, and I hope I can make a positive contribution as we go.
Splendid. Well, I mean, that was fascinating, Catherine, and especially that stat about more people dying from aortic dissection than road traffic accidents. So it's really striking. This condition is have to admit that I knew not very much about, but thank you for informing us all about it. But yes, I think the importance of taking long-term decisions for a brighter future is something that I think lots of people in this conference may be thinking about. But to start off with, Lord Bethel and Juliet, you both mentioned international comparisons, and you both mentioned how we're sort of lagging behind other countries and that we have particular health inequalities. And so, an obvious question, which I feel we do not ask enough when it comes to policy making in this country, what examples of best practice, both in the UK and worldwide, are there to look at? I think, Your Lordship, what should we be trying to, who should we be trying to emulate on this?
There is no clear-cut country that we should just be more like, unfortunately. If it were so, then that would make our lives a lot more simple. There are countries that I do admire. Japan has a very strong culture around food. That means that people go into their later stages of life in pretty good shape, and their longevity reflects the fact. There are countries like Korea, Taiwan, Israel, and Canada that have got a adoption of innovation cycle and velocity that is just staggering, and I admire that terrifically, and patients and their own life sciences industries benefit from it enormously. There are countries that have community health and put an emphasis on at-home treatment and diagnosis that I think charts the way forward for ourselves. But I don't think that there is an off-the-peg, ready-made solution for us to follow.
What a shame. Juliet, do you have any thoughts?
Yeah, I mean, I think I agree with a lot of what you've said. We just don't have an innovation culture in this country. I mean, you take something like mechanical thrombectomy, the first global randomized control trials where there were standing ovations at conferences because the data was so compelling about both its efficacy and its cost effectiveness, date from 20 years ago.
Yeah.
And there have been yet more randomized control trials, yet more evidence, and yet the NHS is so woefully slow to implement something that, so clearly reduces disability, so clearly saves money. I mean, it saves £73 million each year, year on year, and yet we're just, it's painfully slow to kind of get in place all the necessary processes and systems. And you look at our rates of thrombectomy, and the NHS long-term plan says we should be at 10%. We're just over 3% at the moment. Germany is up at 15-20%. Scandinavia is up at those kind of rates. So is America. And it's because they go with where the evidence indicates they should be making the investment. And they put political and funding and other kind of leadership behind it to make it happen. So our problem is not the lack of evidence. I mean, you look at the clinical guideline for stroke that was updated in April this year, the robustness of the evidence for the interventions that make a difference is really strong.
Yeah.
The challenge is delivery, implementation and delivery, and sticking with stuff. And that's where politics does make a difference, because that political leadership for stroke, cardiac and respiratory conditions would make a really big difference, because these are conditions that affect huge numbers where the evidence base is really strong, and yet progress is lagging woefully behind the NHS long-term plan ambitions. And this is where political leadership can help the leaders within the integrated care systems and primary care to prioritise the right things. It's about implementing what we know works. It's not all about the shiny new stuff. I mean, there is shiny new stuff, in AI and technology and digital, don't get me wrong. I think those can make a difference. But so often it's just about getting the basics right, and doing what we've known for years makes a big difference, because that would change
Can I
lives
just
and
build
save
very,
money.
very briefly on that? I think there are two things that stand out for me. One is a culture of risk aversion. People are very, very anxious about changing anything in case they make a mistake. And then secondly is listening to patients. My goodness, we try so hard to put the patient voice in there. We have a patient safety commissioner, we have patient groups, we try to make space for charities, but for some reason the clinical professions just don't listen to or appear to value patient observations. Those two things, I think, hold us back more than other countries.
Very good. I mean, Paul, would you like to come in on that first point about sort of innovation, how we can use it, and even just adopting not even best practice, but stuff that we should have been doing, we know we should have been doing for a long time. And then, Catherine, if you can then talk about your experience of raising issues, as a patient and campaigner.
The NHS can do this. They did it with primary PCI, percutaneous coronary interventions. That's for heart attacks. They did this. So that means when you're presenting with a heart attack and you're blue lighted to a hospital, you are stented immediately, and it saves lives. And they did this, at pace and scale because it worked, and the evidence was there. We need to do exactly the same with mechanical thrombectomy, and for the life of me, I can't understand why we don't. And the NHS can do this at pace and scale. There's an issue about clinicians, and a number of clinicians who can do this, but I think they can be easily overcome by making sure we get IRs and interventional cardiologists doing the work. But that's just my thought. But look, just generally, the NHS is quite poor at learning from itself. And you said earlier about the NHS not being very good at innovation. Actually, sometimes it's very good at innovation because you'll get isolated hospitals, you get isolated examples where innovation does take off quite early on. It's just that it lags in terms of its rollout across the rest of the country at pace and scale, and that's the problem. And this is recognised because we have set up bodies to do just this. We've set up Getting It Right First Time, the name of the gentleman behind it, Professor Briggs, Tim Briggs, he recognises this, and we look into how what works in our NHS, and we recommend that this is rolled out at pace and scale, and sometimes it happens, sometimes it doesn't, but that's why we set up the organisation. NICE, it's National Institute for Healthcare Excellence. Now that is a cost-effectiveness body that looks at how cost-effective certain treatments are, but they're recommended. We've got technology appraisals that were recommended 20 years ago on things like insulin pumps, and now the next is the artificial pancreas. We've got technology appraisals. People have looked at this, but they need to be rolled out at pace and scale, and quite often you've got far too many organisations and trusts and local commissioners that lag. Quite frankly, it's not good enough. We can't continue like this because patients, as a result, are not getting the outcomes they deserve, and we've got to do something about it. And I think, and as I said in terms of my remarks earlier, I think political leadership is required on a lot of these things. There was a view taken some years ago that we need to take politics out of the NHS, that we should let the NHS be independent and let it be run in a way. But if it's an inherently conservative, risk-averse organisation, we do need, and we have political accountability, we do need politicians to say, look, the evidence is here, the data is here, this does work, and we need to pick winners, and we need to roll things out at pace and scale.
Very good. And Catherine?
Yeah, I think it's really interesting when we look, I suppose, at opportunities, what are happening across the world, and also when we think about innovation and where those opportunities might be. I mean, for me, I think the innovation probably sits where we can have, which is much closer to home, I think, is around process design. And when we were talking about good examples across the world, I suppose I'm thinking of the power of good accurate data and how they can inform the design of the systems and services around us. The World Health Organization has produced a new international classification of diseases, version 11, where I understand a number of countries across the world have adopted that. We're yet to adopt that in NHS England, and I think should we move to that, I think it gives a much more detailed and granular data and information, and analysis of this, I think, would enable us to be able to create, I suppose, and design pathways and understand the volumes of conditions that are coming through and target some of the issues. So I think there is an opportunity, not just looking at innovation, but I suppose looking at some of the principles and guidelines that are out there, and I think that that's an interesting example. With regards to, I suppose, campaigning on issues that are important to patients, from very personal experience, been campaigning for change for aortic dissection, and clearly we'd love to have innovation breakthroughs. A biomarker for this condition would be fantastic in the emergency setting, but that's yet to come. And I suppose in the near time, we've been campaigning for an acute aortic dissection toolkit, which has been now designed. That has been co-created with clinicians with patients, with family members, and it's now at a phase of implementation. Something that the charity was really keen to do, I suppose, is that as that toolkit is rolling out, that we were campaigning for an elective toolkit. So how can we get on the front side of this condition, and have been lobbying our Secretary of State for Health and his predecessors for a number of years as well. But I suppose it's about being persistent, but also being able to make a compelling case for change, which we were delighted that we did. And Stephen Barclay has agreed with the Department of Health and NHS England to design an elective toolkit for this condition. And I think that it's, you talked about service specifications, Paul, earlier as well. I think that the toolkit experience for me was definitely a way of accelerating change. Service specifications can take a really long time to design, to get it onto a page, and then to get it off the paper into reality. That's a completely different challenge and job. But I think it would make a fantastic case study. I think the work that has happened around the acute aortic dissection toolkit, around mobilising a community of clinicians, fantastic support from NHS England programme managers and patients involved all the way through. It was fantastic to be part of it and actually to see it start to come to life and actually deliver some change. So although it's still being implemented, the momentum and the support from the clinicians has been pretty inspirational, and I think it's probably because the principles that were designed was very much put into the regional leaders' hands then, so they could make sure they're resolving local issues. So there's standards set, a national standard, but then our regional and local leads on this programme are working to resolve those local issues, and there's certainly a huge amount of enthusiasm and buy-in, and I think a model that would be well worth looking at for some of the larger conditions that we're also talking about today.
Very good. And I'm conscious we've got quite a busy room now, so I think I'll move on to audience questions. So the lady front here.
Thank you. Sarah Woolnough, Chief Exec of Asthma and Lung UK. My question is around moving things upstream, so both around prevention and diagnosis. I've worked in health policy for a long time. We have these conversations. It's very difficult to see the money shift. And Paul, to pick up on your point, this patchiness across the country, that in some places, particularly, for example, around diagnosis, you see good practice, same with treatment, in others, very patchy.
Lord Bethel, would you like to respond to that?
Yes, I completely share your frustration. We saw in the pandemic that we could get diagnostics into people's homes through those swab tests, that we could create data platforms, as Paul referred to, that gave people the data they needed in order to analyse their own diagnosis, and then we could get them treatments sent to their home. And that model is one that I would like to see pushed through the system much more energetically. And frankly, far fewer people actually go to hospital at all. People don't like going to hospitals. Most of our hospitals are sited in very inconvenient locations. And therefore, getting the health and care service into communities and into their homes is a real priority. But also the preventative upstream measures on asthma and lung conditions. I am very pro-ULEZ because for me and my family, living in Notting Hill just underneath the A40 Westway, it's cleaned up the air dramatically and improved my health and that of my family a lot. And I think there are a lot of people in London who would say the same. Implementation really important, making sure that you have the right transition arrangements is very important, but those kinds of measures are the kinds of things that I would like to see on the political agenda, and for politicians of all parties to be driving through much harder.
Very good. Sorry, Gia.
Yeah, no, I mean, I don't know, I think I've been around the block for too long. I mean, how long have we been talking about the importance of prevention and moving money upstream? And I think the frustration is that so many of the evidence-based interventions that could really reduce the burden on the NHS are so relatively simple and cheap to deliver. I mean, if you look at, I don't know, hypertension detection and management, you know, it's not beyond the wit of man to make every contact count and to ensure that when somebody is at any point in the health service, be it in a pharmacist, in primary care and secondary care, they have a cuff put on them, but also their atrial fibrillation is detected at the same time. We know if you do simple things like that, you could prevent 150,000 strokes, heart attacks and dementia cases by 2029. They're cheap, they're easy to do, but you've got to get everybody lined up. And you've got to have that, again, political leadership and push to really make it happen. And physical activity is another one. I mean, physical activity doesn't cost anything, and yet we know that physical activity, physical inactivity is responsible for 40% of all long-term health conditions. And I got the privilege of chairing the Richmond group of charities. We have this wonderful partnership with Sport England and a public-facing campaign called We Are Undefeatable, which is people with long-term conditions showing how they have managed to get physically active. It doesn't cost anything, but it does need political leadership, and it needs all the kind of incentives in the system, including the financial flows, to make it happen.
Paul, did you have any thoughts on that?
Well, look, I mean, unfortunately, as we all know, the secondary care settings suck up money, and quite frankly, I'm not suggesting we don't fund our hospitals adequately, but in terms of bang for your buck, if you've invested in preventative measures, primary care, community pharmacy, that's something we've not talked about, already, then I think, our outcomes would be much better. This is no longer... I went to a speech by the then Secretary of State for Health and Social Care, and I can't remember where exactly it was or who organised it, but it was Sajid Javid, and it was a planner all around, this is no longer... The escalating health budget means that prevention has got to be, the top of our list. It's no longer a nice to do. It's no longer something that kind of sits, kind of over there and we let them get on with it. This has got to be crucial to our long-term management of our health service. And if we don't do it, we'll suffer the consequences, not only in poor health outcomes for individuals, but a colossal NHS health budget, which means there's less money to spend on all the other things we need to spend money on.
I agree.
Catherine, do you have any thoughts? Or shall I?
No, I suppose just a very small build, really. I think underlining your tweet again, we're really not short of opportunities here. I think it's understanding, I suppose, how we prioritise and then where we take the action. For me, I am thinking about the future when I think about prevention, and I suppose where the role of education for our children today. We talk about people. Being able to take ownership for their health, and I think actually there is a role in education in our schools to teach the future generation really how to look after their hearts and their health, and there's a significant opportunity for investment there, but as you say, we're not short of opportunities.
Yep.
It's where we want to go with it.
Yes, I mean, as a young journalist, I'm probably not the best marker for teaching young people about healthy practices, but there we go. Anyway, another question, please. The gentleman at the front here.
Hi there, thank you very much. I'm Ollie Parsons here from Versus Arthritis. There's over 10 million people in the UK with arthritis. It's recently been recognised in the Major Conditions Strategy as one of the major conditions. You've mentioned economic inactivity. Just wondering what the panellists think about what further employment support there could be for people that are both in work with long-term conditions such as arthritis, or that are out of work and unable to work because of something like an MSK arthritis condition.
More Bethel?
I think we haven't got it quite right in terms of offering people with conditions the support that they need, either financially or with workplace support. There's a huge amount of interest in this from businesses as they face a workforce crisis. I'm on the board of Business for Health, which is a business-led organisation looking at ways in which we can support and help those in the workforce to have good mental health and good physical health. And I think that there is a widespread recognition that it's we're not doing enough to ensure that those who maybe drop out of work in the short term because of a condition like arthritis or mental health issues or any other are given the support that they need so that they can return promptly and effectively.
Yeah, I mean, I just want to say it's brilliant news that musculoskeletal conditions, including arthritis, are now recognised as major conditions. Because 10 million people affected by the condition is a lot of people, isn't it? And I'm sure all your data tells you that a lot of them are of working age and want to stay at or return to work. I think the thing that I would say is this is where the voluntary sector, this is where charities, both national and local, can make such a big difference. We're really trusted by patients living with our conditions. All of us have absolutely fantastic, high quality patient information, helplines, websites, and a lot of us employ care coordinators who can really help people living with those conditions to understand what support and resources are out there, what questions to ask, and what they should be demanding, because I'm a big believer in patient power. If you equip your patients with the kind of, if they know what good treatment, care and support looks like, they jolly well need to be asking for that. And I think that's where the voluntary sector has a huge role to play, both in facilitating patient voice and patient advocacy, but also in providing sort of really great services that are personalised, that really focus on the outcomes that matter to people living with these conditions. So yeah, you're doing great work at Versus Arthritis.
Very good. And time for another question. I think the gentleman on the end here.
Yeah, afternoon. Phil King from Harborough in South Leicestershire. What I wanted to ask you is what you're describing is possibly, is it symptomatic of a malaise within the health service, the way the whole of the health and social care system's structured? Because if people don't have mechanical thrombectomy or other very simple, cost-effective treatments, the knock-on effect is they then have to have social care, whether they pay for it themselves or the state, local council taxpayers pay for it, and that's a very expensive business and a very heavy burden on residents. I'm a councillor in Leicestershire. It's one of the biggest things we have, and yet the vast majority of people will not need that care. The problem is the NHS isn't helping us by not delivering these treatments. It's the knock-on effect on the whole sort of rest of society. Thank you. I wonder what you think about that.
Well, yes, a lot to cover. Paul, are we still living in the downstream of Bevan's mistake in 48 or whatever, or is there a way the NHS is actually able to cope with these issues?
I wouldn't necessarily call it a mistake, but I would say, look, the NHS was set up as an organisation that's there to fix you. When you're ill, you present yourself at your GP or then go to a hospital and you're fixed. That's the theory, but we no longer have that virtue by the fact that we've got so many people, as we say, living with long-term conditions. The NHS is there throughout your life, because we've kind of got to change that. I think there's probably a few reasons why the NHS is slightly risk averse and doesn't adopt innovations at pace and scale, and some of the things we've talked about. I think it's always very difficult for any large bureaucracy to change. Can do. It did during COVID. It can do, and I think we've got to kind of think the lessons of COVID and think of the lessons when the NHS has changed, and look at other big bureaucracies that have changed. But it's difficult. But we need to. It's as simple as that. I also think there is an element of headspace. I think a lot of clinicians, we have a workforce challenge in the NHS. There's no doubt. I don't think we have a financial challenge, by the way. I think the NHS, the increase in budget the NHS has received has been considerable. What we have is a workforce challenge and the efficient spend of that money. And I think there's an element of headspace where clinicians probably do, and managers and all the others, because they're firefighting with certain different challenges that present themselves at that particular moment. They don't have the capacity to sit back and think, right, how are we going to redesign this system? How can we make this better? Because they're too busy sort of fighting fires. And to be honest, and I completely agree with the contributors, all my panellists, that I think that's for politicians, quite honestly, political leadership can help a lot of those challenges. It doesn't help on the ground where they have to redesign a system in particular, but I think you need the political will to try and change some of those things.
Very good.
Can I just build on what Paul was saying in terms of, we've sort of moved on to blockers of innovation. I think I completely agree with the points Paul made. The one that I would sort of build on is to say that we don't speak nearly enough about the culture within the NHS. It's 2 million people. Yeah. And it's 22,000 organisations, if you look at it at its most fragmented. And there's something going on there about the hierarchical dogmatic nature of the business culture. Not all of the NHS. It's very variegated. There are some, as Juliet was referring to, there are some places that are racing ahead on innovation, and individual departments and individual organisations are absolutely fantastic. But quite a lot, a quarter of it is often left behind, and en masse it is off the pace. And that is, I think, a lot to do with the relationships that are had between management, between senior consultants, between frontline staff. There is something slightly dysfunctional about the way that works, which means that people find it difficult to adapt to change, and we should be talking about the NHS culture
and financiers
a lot
as
more.
well. And
And
financiers.
incentives, financial incentives have got an important part to set that culture.
Yeah, I would just add two things that I really agree with your point. I think the first is there really is a place for national standards and national ambitions. And, at the moment it's all being devolved to the integrated care systems who are saying we're in charge. Well, actually, I think there's a balance between kind of national and local here, but I think national standards definitely have a place. Second thing I would say is just picking up your point about the lack of headspace within the workforce at the moment. I mean, everyone is exhausted. I think there's a will to do things differently, but there's a lack of kind of time and support for quality improvement. And I mean, I would make a plug here for clinical networks. The Stroke Association's been supporting the integrated stroke delivery networks with 6 monthly residentials. And those have just been fantastic because we've been sharing the data, we've been sharing good practice, we've been learning from each other. There's a whole community of sort of peer support to drive the kind of innovation and transformation agenda. Clinical networks are all at risk at the moment because of the cuts to regional and ICB budgets, and I think there's a real risk if those clinical networks go that we're going to see yet more dilution of good evidence-based practice.
Very good. I think we've got time for another question. The lady in pink along there.
Thank you so much. So my name is Valerie Farr and I'm a patient representative of the Royal Osteoporosis Society and Sunday Express Better Bones campaign, which is aiming to have 100% coverage of fracture liaison services in NHS trusts. Would completely agree with what Juliet has said about kind of frustrations in terms of inequalities and also kind of, lack of cross-party political leadership for long-term health conditions and preventions. So osteoporosis is a long-term condition and it affects over half of women over 50 and 1/5 of men. And the burden of preventable fractures caused by osteoporosis on the NHS is absolutely enormous. Over 1 million acute hospital bed days are taken up by hip fracture patients and £2 billion is spent annually on hip fracture care. But half of hip fractures could have been prevented if people had had access to fracture liaison services, which are the gold standard for systematically identifying, assessing and treating anyone who breaks a bone after the age of 50.
Madam, I am sorry, but we are a bit tight on time, so if we could move towards
okay.
I know it's very obviously an issue that's very close
Well, it
to
is.
heart,
I mean, basically, access to kind of fracture liaison service could prevent 90,000 hip fractures annually. And does the panel agree that something like this is worth pushing upstream? And how do we do it?
Well, I mean, perhaps, Paul, you could talk about how we do it, but I would just, first of all, Catherine, is it similar to your experiences with your
Yeah, it is actually. We were just on that particular issue, I suppose, of trying to tackle access and identifying issues early. I mean, there was a lady I was speaking to yesterday when we were putting together some of our resources to support people's mental health, and she was sharing her personal story, actually, where she was diagnosed with hypertension, but then the delay for treatment, in fact, she was never treated for hypertension. Her treatment was surgery for an aortic dissection that happened 2 years later. So it's a different example for her. I mean, the outcome could have been absolutely catastrophic. I'm sure she's not alone, but I think, access to early treatment, especially once the condition has been diagnosed, is absolutely vital, absolutely vital.
And Paul?
You'll know better than me the virtues of the systems that you're suggesting. I mean, and if this is the early diagnosis and the pre-treatment plan that you think are right for people with osteoporosis, then osteoporosis, sorry, forgive me, then to your knowledge. What I would suggest, how do we get this? Well, there are numbers of levers and systems, levers and drivers within the system. I've worked in healthcare policy for 20 years. There are all sorts of different levers and drivers within the system. You've got to find the right one that allows the NHS to do this at pace and scale. If you've got the Sunday Express behind you, I congratulate you on your campaign. It will be something like GIRFT, it will be something like tariff, it will be something like this, which is the right means to get this innovation adopted at pace and scale. And if you've got examples where the NHS does this well, but examples where this works, then that's the model you want to see adopted across the country, and I wish you well on your campaign.
Very good. I'm conscious that we're coming towards the end now of our session, so I just wish I could ask Juliet to give us a brief summary of today's, or maybe just give us a sort of well-rounded conclusion.
Yeah, I think it's been a really great conversation. Guess what? We've come back to we need to invest upstream. Let's have a well-being service, not just a treatment service in the NHS, and let's really invest properly in primary and also secondary prevention. I think we've heard about some of the blockers and barriers to innovation, including ones around culture and processes, but also a sense that actually innovation can be delivered at pace and scale when there's strong political leadership. And I think, your campaign is just a fantastic campaign, and doesn't it exemplify the power of the patient voice? And how we've just got to keep the people who matter here, who are patients and their carers, front of mind in everything that we talk about, because they are our North Star, and they will make sure that we focus on what really matters.
That's right.
Splendid. And on that note, ladies and gentlemen, can I ask you to give a big hand to our panellists? And thank you all very much for giving up your time for our events today. And enjoy the rest of the conference, ladies and gentlemen.
Yeah, see you later.
Very nice to see you.
Yeah, really nice to see you.